Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 19 of the OBGYN podcast. Today, we are going to be bringing our discussion of intrapartum fetal monitoring to a close by discussing two of the newer technologies, fetal pulseoximetry and ST waveform analysis. So without further ado, let's get started with episode 19, Intrapartum Fetal Monitoring, Part 3. When we started this discussion, we were talking about identifying the at-risk fetuses so that we could intervene. Over the years, fetal hypoxia became the working hypothesis as to what was causing these injuries, and all the approaches were aimed at detecting this decreased fetal oxygenation. At first, we tried to identify the fetal heart rate patterns associated with fetal hypoxia, with, as we have discussed, limited success. In order to remove a level of abstraction, we added fetal scalp pH, which is still a surrogate for fetal oxygenation because as fetal O2 falls and CO2 rises, the pH falls. This approach added to our ability to identify hypoxic fetuses, but the false positive rate was still too high. In addition, it required special equipment and training and came with its own complications. The discovery of scalp stimulation has eliminated the need for scalp pH and its complications, but still, neither is specific nor sensitive enough to add much to our treatment algorithm. So how do we remove all of these levels of abstraction? Well, we need to measure the fetal oxygenation status directly. Now we do this all the time in adults and children with the use of a pulse oximeter. The underlying technology was actually invented in 1935 by Dr. Carl Mathis, but commercially wasn't available until 1981. Now Dr. Mathis used a red and green light, which were later switched to red and infrared. These two wavelengths are absorbed at different rates by oxygenated and deoxygenated hemoglobin. The oxygen saturation is found by shining these lights through a translucent portion of the body, and a receptor on the other side records how much was absorbed. These values are then compared against a standardized table to come up with oxygen saturation. Now, because we are measuring at a peripheral site, this is not a true indication of arterial oxygen saturation, but it's close enough for clinical work, and except in a few isolated cases, it actually correlates extremely well. This technology was iterated upon over the coming decades to improve its reliability and also to decrease the size of the probes. As I mentioned, it was commercialized by Japanese bioengineers in 1981 and made a huge splash in the medical world. As you can imagine, this especially revolutionized the delivery of anesthesia, where being able to keep an anesthetized patient well oxygenated is key to a good outcome. But this revolution wasn't limited to anesthesia and rapidly spread through all aspects of healthcare. One of the places that had the largest effect was actually in neonatal care, because neonates thrive in a very narrow range of oxygenation. Too little can cause brain damage and failure to thrive, and too much can cause retinopathy. In the 1980s, obstetricians and neonatologists took this a step further by considering if this technology could be used to directly measure the oxygen status of the fetus. This would remove all those layers of abstraction that we've been employing to determine the fetal status. As you can imagine, this is much more complicated than trying to measure the pulse ox in an adult. As I mentioned, traditional pulse ox machines shine light through a portion of the body and measure how much light makes it through by using a light receptor on the other side. In a fetus, we don't have that kind of access, and so new technology was needed. Researchers found that instead of measuring the transmitted light, we could instead measure the reflected light. And early studies demonstrated that the probe would need to be attached to non-hair-bearing and non-edematous portions of the head, and so the fetal cheek or temple became the accepted placement for these probes. In fact, electrodes were added to the probes to measure the electrical impedance of the tissue that it was in contact to, in order to ensure that it's in the right place. This works because the fetal cheek has a different impedance than either maternal tissue or the fetal scalp. Early studies demonstrated that this was feasible and came up with standardized tables used for calculating the fetal oxygen saturation. This early work found that the normal oxygen saturation for a fetus is between 35% and 65%, and that acidosis does not occur until the oxygen saturation falls below 30% and stays there for at least 10 to 15 minutes. So using this data, clinicians designed some studies to see whether direct measurement of the fetal oxygen status could be used to detect the at-risk fetuses. The first one I want to look at is from Thomas Garit et al. From the Gray Journal in 2000. They undertook a large randomized controlled trial involving 9 centers. They were very smart about it, and they parsed the trial into 3 phases. In the first, they just recorded the number of cesarean deliveries done for fetal distress alone, and for fetal distress with labor dystocia. This served as a baseline for the study. They then trained the participants how to apply and interpret the pulse ox machine, and then monitored the use in 15 to 25 labors. Only then did they start the randomized trial. Now, I highlight all of that just to say that they really thought this study through and tried their best to reduce the number of confounders. In any case, they randomized 1,010 women into either standard care with electronic fetal monitoring or to the addition of the fetal pulse ox if warranted. They categorized the fetal heart rate tracings into 3 groups, which are very similar to the NICHD guidelines that we talked about in the last episode. Category 1 was allowed to labor without using the pulse ox. Category 3 was considered ominous, and the fetus was delivered without further intervention in either group. And so what we're really talking about here is the Category 2 tracings. This, again, is good study design because it's exactly the babies that we're worried about. For those concerning tracings in the fetal heart rate only group, they use conservative measures and scalp stim to reassure the provider. If the tracing remained non-reassuring, they moved to delivery either by cesarean or operative vaginal delivery. In the pulse ox group, they applied the probe to the fetal cheek. If the oxygen saturation was greater than 30%, they considered that to be reassuring and continued the labor. If saturation was less than 30%, they reverted back to the standard fetal heart rate algorithm. They found that the number of cesarean deliveries performed for non-reassuring fetal heart rate tracing was 10%, and for non-reassuring and fetal heart rate tracing and dystocia together, it was 7%, for a total of 17% C-section rate. With the addition of a fetal pulse ox, they found a reduced rate of cesarean delivery for non-reassuring fetal heart rate tracing to 5%, and they also found a slight reduction in the number of C-sections for non-reassuring with dystocia to 5% as well. Interestingly, the number of cesareans performed for dystocia alone increased from 9% to 19%. This resulted in the number of cesareans and operative deliveries being the same in both groups. They found this was because women who were being delivered for non-reassuring fetal heart rate tracing in the control group were now being delivered for dystocia in the study group. It didn't change where the women ended up, it just changed the reason they got there. Now I want to go back to their introduction and quote the objective. They wrote, quote, "Given the rarity of adverse outcomes in monitored fetuses, we chose to test for an improvement in fetal assessment by evaluating whether fetal pulseoximetry allows a significant and safe reduction in cesarean deliveries done because of non-reassuring fetal status. If the oximeter has greater specificity than electronic fetal heart rate monitoring to determine the absence of significant fetal hypoxia, the clinician might safely avoid unnecessary operative interventions for non-reassuring fetal heart rate patterns." End quote. For reasons I have beaten to death in the last 2 episodes, they chose not to make neonatal health their outcome. And in their study, they found no difference in APGAR scores at 5 minutes or the need for intubation. Although pulse ox was better at detecting increased base excess, although still only 30% of the time, it was no better than fetal heart rate at detecting a pH less than 7.05, with only 10% of neonates in each group who were delivered for concern for acidosis actually being acidotic at delivery. That's 10%. So 90% of the C-sections that were done for concerning fetal heart rate tracings, the babies were actually not acidotic. Now, there were several more studies looking at fetal pulse ox, but I'm going to skip ahead to a Cochrane review from 2014. They included several trials, and they had similar findings. In all but one study, they found that although the number of cesareans performed for non-reassuring fetal heart rate tracing was lower with the addition of the pulse ox, it did not change the overall cesarean rate, and therefore they did not recommend its addition to labor management. So why didn't it work? It seems like it should, right? Well, I have started to look at this from 2 different directions. From the fetal side, it all has to do with our assumptions. As I spoke about in the last episode, we have been assuming for 60 years that poor outcomes are due to fetal hypoxia, and we have slowly been marching down levels of abstraction until we got to fetal pulse ox. And we have found that even when we can monitor the actual intrapartum fetal oxygen saturation, that we still cannot accurately determine which babies will have a low pH. And we know from the last episode that not even pH correlates well with outcomes. This is why so many of the papers in the last 20 years have stopped focusing on neonatal outcomes and instead looked at the second direction, reducing unnecessary interventions. But this is a fundamentally different goal. This is about making us providers better at not intervening, and this is a very difficult problem. In obstetrics, we rarely get sued or face upset parents for doing a cesarean delivery and presenting them with a healthy baby. But we do face issues for the opposite. So the natural pressure on the provider at the first sign of quote unquote distress is to intervene. So you would think that anything that reduces the false positive rate of fetal heart rate tracings would be welcome. And that is why I find it so interesting that the overall section rate didn't change with the pulse ox. By starting with fetal heart rate tracings, have we backed ourselves into a corner? Perhaps we can't do much better than we already do with the NICHD guidelines, and if we really want to reduce interventions, we should look at other causes like labor dystocia. Now, let's keep those thoughts in mind as we move on to the next and last method, ST waveform analysis. This technology started in Sweden and spread throughout Europe during the 2000s before being approved for use in the US in 2007. Okay, so how does it work? Well, unlike traditional fetal heart rate monitoring, which abstracts the fetal EKG, as we have discussed in the first episode, ST waveform analysis looks at the raw EKG data obtained via fetal scalp electrode. In animal studies done in the 1990s, it was shown that as intrapartum hypoxia worsens and anaerobic metabolism increases, it causes a drawdown on the glycogen stores in myocardial muscles. This causes a depression in the ST waveform and can also cause negative T waves. Using this information, trials were performed to determine whether adding this analysis to traditional fetal monitoring decreases intervention rates or possibly improves outcomes. And I want to go through two of these. Let's start with one of the first trials to look at it. This is from The Lancet, published in 1992 by Westgate et al. This was performed at Plymouth General Hospital in England starting in 1990. Prior to the study, their hospital had a 9.5% section rate, 8.5% operative vaginal delivery rate, and a perinatal mortality of 6 per 1,000. Women were randomized to either standard electronic fetal heart rate monitoring or ST wave analysis when the decision to use an internal scalp electrode was made. This is obviously a selection bias here at play, and we'll keep that in mind. They state indications for use of scalp clip were preeclampsia, growth restriction, diabetes, TOLAC, meconium stained fluid, epidural analgesia, augmentation, or abnormal fetal heart rate pattern. Now, as you can see, that is a very diverse group of labors. In their protocol, they also utilized fetal scalp pH when tracings or ST segments became concerning. So they are not only combining traditional fetal heart rate monitoring with the new ST waveform analysis, but also still using scalp pH, which means that they are now using 3 different techniques to monitor the fetus. When we start to interpret the study, we need to look at their neonatal outcome criteria. They considered any of the following criteria to be signs of quote-unquote birth hypoxia. Cord pH below 7.05 with a base excess of greater than 12, APGAR less than 7 at 5 minutes, any need for resuscitation, hypoglycemia, seizures, need for ventilation, or death. Now, from the last episode, we know that pH and APGAR scores are not very good predictors of neonatal outcomes, so we can already tell that they're going to have issues trying to make any conclusions from their neonatal data. In any case, in the 9 months of their study, they had 3,580 deliveries, and 1,221, or 34%, had a scalp clip placed for any reason, which seems awfully high, at least to modern standards. The women were equally divided between the two groups. Women in the ST group were much less likely, 4.4% versus 9.6%, to undergo operative delivery of any type for fetal distress. And contrary to what we saw with the pulse ox, there was no difference in operative delivery for failure to progress. And not surprisingly, when they looked at neonatal outcomes, there was again no difference in any of the measured outcomes. This reduction in interventions is nothing to sneeze at, but it bears keeping in mind what was needed to achieve it. Rupture of membranes was needed to be able to place a scalp clip, which we know is associated with higher chorio rates, and then also scalp pH with its attendant risks was also utilized to further classify these fetuses. The cost, training, and equipment needed for these additional tests is also something to keep in mind. So why pursue any of this? Well, thankfully, the authors address this, so let me quote them. Quote, "It has been assumed that similar levels of non-intervention can be achieved by means of better in-service training and fetal heart rate monitoring. In practice, such improvements are difficult to achieve and indeed have not been achieved despite 30 years of electronic fetal heart rate monitoring in labor." Unquote. This failure to improve our ability to interpret traditional fetal heart rate tracings drove so much of the research into all these techniques that we've heard about over the last 3 episodes. And consequently, the failure of these techniques to significantly change outcomes caused us to reevaluate how we interpret those tracings to begin with. And as we saw with fetal scalp pH, scalp stimulation, and fetal pulse ox, as we got better at interpreting tracings, the gains from these add-on tests become smaller and smaller. So, why don't we skip ahead here and see if the same pattern holds true for ST waveform analysis? To do that, I'm going to look at a meta analysis published by Gabriel Saccone et al. In the Green Journal in 2016. They reviewed 6 randomized controlled trials of ST waveform analysis, starting with Westgate's in 1993 and going up to 2015. In all, it included 26,000 women. They found that there was no difference in any neonatal outcome, including acidosis, admission to NICU, acute neurologic injury, or death. This would be a good sign if the intervention rate was also decreased, because it would mean that despite reducing the number of operative deliveries performed, there was no increase in neonatal harm. However, when lumping together all the studies, they found that the decrease in intervention seen by Westgate disappeared. If you look at the studies, you can see how as the years go on, the differences between the groups all but vanishes. In the 1992 Westgate study, it was 40.7% versus 33.2%. In the 2001 Amber-Whalen study, it was 20.4 versus 18.1. In 2006, it was 15.4 versus 16. And in the largest study published by Belfort in 2015 with over 11,000 women, it was 22.2% versus 22.8%. Like I said, I think it just proves that Westgate had it wrong in 1992. What he said was quite right for the time, but in the intervening years, we have gotten together and standardized how we interpret fetal tracings. And importantly, we have incorporated the findings from all these attempts to reduce our false positive rate without the need for further tests. We seem to be stuck with our current paradigm of electronic fetal monitoring, so how can we make it better? Well, first we need to face the fact that maybe we can't improve outcomes for neonates. But perhaps we need a more realistic goal, which is reducing obstetric interventions. I think we should have learned by now that many cases of perinatal injury are not due to intrapartum hypoxia, and if they aren't, then there's no way that we're going to detect them nor prevent them. So the best we can do is try not to intervene in otherwise normal labors when we don't need to. In that vein, I think there is promise in recent developments in machine learning. We all know that if you give the same tracing to 3 different providers, that you're going to get 4 interpretations. If we can find a way to eliminate that subjectivity, we will at least have a better data to work with, and machine learning seems to be the best way to accomplish this. The way this works is by feeding the algorithm thousands of raw fetal heart rate tracings and neonatal outcomes, and then asking the system to look for ways to identify them. Now, of course, this is dependent on what information we feed in and what outcomes we choose, so there is still a large margin of error. But I think this is the next big step for us here. I'm not the only one who thinks this, and you can find several papers looking at this. We are going to be seeing this a lot more as we start collaborating with our colleagues in computer science. There is one paper from the Innovative Applications of Artificial Intelligence conference in 2010 that I want to highlight. A group from McGill University designed a machine learning algorithm, and after 12 cycles, they were able to attain a false positive rate of just 7.5% and a specificity of 50%, which is not bad for 7 years ago. But importantly, they also compared it against a human expert and found that it outperformed at least that one human. Again, I think this will eventually take the place of manual interpretation, but for now, at least it can help us get even better at interpreting fetal heart rates. Going through this process of reading and thinking about all the articles and techniques for this series of episodes, I am really struck by how the best intentions can have such unpredictable results. As they say, the road to hell is paved with good intentions, and although I wouldn't say that intrapartum fetal monitoring is hell, I can say that we definitely did not end up where we wanted to be. In trying to save babies, we have created a whole nother problem around interventions. From a clinician point of view, we need to recognize the limitations of our current system to monitor fetuses during labor and know when it is okay not to intervene. The NICHG system helps a lot with this by its third category. It still leaves category 2 as the ones we need to worry about, but knowing that less than 10% of babies with a category 2 tracing will have acidemia, and that only a portion of those babies will have injury, should allow us to be much less aggressive in intervening, especially when the labor is progressing normally. We have to remember that even though the deleterious consequences of overintervention aren't seen for many years, that they are real, and if we want to do right by Hippocrates and quote, do no harm, then we must consider them before we decide to do an operative delivery for fetal distress. There are so many fundamental issues wrapped up in our discussion about intrapartum fetal monitoring, from how do we define bad outcomes, how do we conduct research when some of those outcomes don't happen for years, how do we utilize tools that we know are bad, How does societal pressure surrounding lawsuits affect medical care, to even things like women requesting cesarean deliveries because they want no chance of injury to their baby? I could spend another 3 episodes breaking all of this down. But first, I'm not sure I'm even smart enough to do that. And second, there are other topics I want to move on to. So I think I'm going to wrap up intrapartum fetal monitoring here. If I could give one takeaway from these episodes, it is that we need to know when we don't know and recognize the limitations of our knowledge. And from a historical point of view, we need not to implement new technologies before we understand their strengths and weaknesses, because that is how we got here to begin with. I hope that these episodes have been interesting to all of you. I know that I came out of it with a whole new perspective on something so pervasive that I never stopped to question why we do it. My feelings on this subject are complex, and I apologize because I feel like I wasn't as clear on some of the points as I would have liked to have been. Over the last 3 episodes, there are dozens of papers you can go through, and I encourage you all to read through at least some of them and come to some of your own conclusions. As always, if you like the show, please consider dropping a review in iTunes so you can help others find us here. And you can send any thoughts to feedback@obgyn.fm. We have a new Journal Club episode coming next week, and I put the article in the show notes today so you can all get prepared. Then we have a busy summer planned here with some new episode formats, another guest episode from Dr. Kim, and then some GYN topics to tackle. This is all possible because of all of you dear listeners, and so I thank you all, and I hope you'll join us again next week.